Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to Health Lyrics, who is our Newsday show sponsor, for investing in our mission to develop the next generation of health IT leaders. If you want to be a part of our mission and become a show sponsor, send an email to partner@thisweekinhealthit.com. Quick note, we launched a new podcast, Today in Health IT. You can hit it at todayinhealthit.com. You can subscribe wherever you listen to podcasts. We do a roughly a 6 to 8 minute show every weekday morning. We take a look at one news story and we break it down for you from a health IT perspective, from a CIO perspective. And it's a great way to stay current, great way for your staff to stay current. So recommend it to some friends as well. Check it out, subscribe wherever you listen to podcasts. Okay, today we are joined by Ann Weiler, who is a health tech entrepreneur, actually recovering health tech entrepreneur, I guess we'll call you, and advisor to This Week in Health IT. You have been for over a year, and I'm looking forward to this conversation. Good morning, Ann. Welcome to the show.
Hey, Bill. Thanks for having me.
So one of the rotating co-hosts of the Newsday show, and the thing I'm looking forward to with you is, I talk to a lot of people who are inside of the provider space, and you are technically outside of the provider space. So we're going to talk a lot about different things that are going on the periphery, things that are going on in the tech community and those things. But we're also going to touch on the, we have to talk about vaccine distribution. It's top of mind for everybody. We're going to talk about the vaccine credential initiative a little bit. And I think where we're going to start, though, we'll start with JP Morgan. You did not get to attend, but I did attend. Mm-hmm. So we'll do this as I'm telling you what went on, and then you can comment on it. Now, the JP Morgan conference for me is a chance to really sit in on some board discussions, right? So you get a chance. For me, I sit through the nonprofit track. And this year it was Advocate Aurora, Prisma Health, Mass General, Brigham, Intermountain, SSM, Baylor Scott and White, Northwell, Common Spirit, Ohio Health, Blue Shield of California, Spectrum Health. That was day one. Advent Health, Ascension, Jefferson Health, Providence, Henry Ford, and ProMedica was the second day. The reason I sit through this is, it's the CEO, CFO presenting to institutional investors, bondholders and the like, and they sort of talk about what happened last year. They talk about what they're projecting to happen this year, and there was a lot to talk about. And then they also give you a snapshot into the financials. Now, some were more, let's just say, open with their financials than others. Some you got a full picture of their balance sheet and their operating margins. Others were a little coy with how they presented it. But that's their prerogative and whatnot. But for me, it's a chance to say, all right, what happened this year? And, as we looked at it, what happened this year is exactly what we thought. From March, April, May, roughly the end of May, you saw this big donut appear in everybody's financials. And it was as obvious as you can be. You didn't need an MBA to figure this out. You just looked at the financials and you're like, okay, this was the curveball. Everyone had to deal with it, and we got to see how they dealt with it. Now, I thought one of the bigger themes from this year was again, just diversification. If a health system was diversified going into COVID, they weathered the storm pretty well. Now, most of them weathered the storm pretty well. I mean, you're talking about some established health systems here. If they weren't diversified, they recognized that early on, and they went out and they shored up their balance sheet. They went out and they borrowed money. They made sure they had access to capital throughout COVID. And almost everybody, actually everybody who was on this list received CARES Act money, and that filled, let's just say, about 3/4 of the hole, maybe 2/3 of the hole that was created during that time. But the challenge was that was the gaping hole. But then the health systems had to figure out a way to get people back. And while it popped back pretty quickly, it's still not back to 100% for most of these health systems. I guess, bringing you into this conversation, what do they need to do? Are we going to return to what it was like before? What kinds of things are people going to do to get people back and get those volumes up? And is that just a pipe dream? Have we now moved into a different model?
I hope we've moved into a different model. I'd be interested to know whether you saw telemedicine hitting, like, were there actual revenues there? Because in the beginning, it was being reimbursed at the same rate as in person. And so this is obviously, I'm both a person and a pundit now.
Yeah.
Thank you for making me a pundit. But, I remember trying to do an online visit with UW, University of Washington Medical Center here in Seattle when COVID started. And I think I was like 12 hours on a waiting, like all day long, refreshing. You're waiting, you're bumped down, you're up, you're down. So like the volumes of telemedicine in the beginning were quite high. Now there's this question of, is the reimbursement going to stay at the same level? So how much was that coming into it? But when we think about like the levels, there was this, obviously elective surgery is the revenue driver, and so many elective surgeries were canceled or postponed. I don't know that they're quite back yet. And those elective surgeries are not, this is not cosmetic surgery. This is, knee replacements, but also follow-up from cancer surgeries. Like, again, anecdotal, but a friend of mine had survived colon cancer this year, and the removal of his, I can never say that, the ostomy bag, was considered elective surgery.
Yeah.
And that got postponed as with another wave. So it does, like, I think there's going to be a ton of pent up demand, because those are the things. There's a whole bunch of, like, brain surgery. If it's benign, that's also elective, believe it or not. So, if you stack rank these, like, things that are urgent, all of those surgeries need to happen. And then we're going to have this huge backlog of, the knee and hip where, you're in pain, but it's not life threatening. So I think there's definitely, I think, two things. One, I think we saw at the beginning, one of the things with telemedicine has been the physicians. Like, again, Twitter is such a great source of information. I remember the beginning of the pandemic, number of physicians that I follow were actually tweeting like, oh, you can do a visit without putting your hands on the patient. And as much as, no, I'm serious, like, as much as, like,
I know.
as much as we know that this is true, a lot of them had to experience it.
Yes.
Yeah. So I think, and then there becomes this question of this licensure thing, is that if those restrictions are lifted or make it easier to do cross-state telemedicine, then what happens? Is now every health system in competition with each other if you can get a patient from, a different state?
Yeah.
Things are going to change.
So you brought up a lot of stuff. So first of all, we need to do an education process on what elective surgeries means to the general public. When they first heard that, they were like, yeah, that makes perfect sense. Now, anyone who was in healthcare was like, oh my gosh, do you realize what you just did?
Right.
And actually, I think there's an awful lot of hesitancy to do it again. They have set triggers in certain states. They've set triggers, and if positivity rates or a number of ICU beds or certain things fall below a certain threshold, they will institute moving the elective surgeries out, or the non-essential surgeries, or whatever terminology you want to call it. But health systems are doing everything they can to make sure that does not happen again.
Right.
And so that was a huge thing. But the even more concern, so surgeries drive imaging, they drive labs, they drive an awful lot of things that drive the revenue in the health system. The second thing that drives their pipeline is ED visits. Mm-hmm. And the emergency rooms are still down close to 14, 15, 20% in some cases.
Yep.
And if that's your feeder, you've got to find another feeder. So that was one of the things that really came through is they have not come up with good strategies to get people back in the ED. There is still a fee for service world. And the reason I thought one of the themes was diversification is almost everybody's talking. We've been talking about it for the better part of a decade, if not two, in terms of moving from fee for service to, more of a at risk for health. But nothing like an emergency like this to really drive home the point that if you're relying this much on fee for service, you're at risk. Essentially, is what's going on.
That reminded me when you talked about the ED. Did you see the article, the study from Boston Children's about asthma?
I did not.
Visits?
I didn't.
Down significantly, and no impact, like not, no greater number of children being admitted with severe complications, which kind of makes you wonder about, when you think about the I don't want to say over treatment, and obviously any parent whose child can't breathe, it's a very scary situation, but they basically saw significant decrease in these ED visits without any, as far as they can tell, any impact on actual health.
I'm John Brownstein's going to come on the show. I'm scheduled to talk to him in a couple of weeks, and I'm looking forward to it. So he's like their data guru slash.
He's their chief innovation officer and an epidemiologist.
Yeah, and he's on the news all the time now in their market and talking about this. So it'll be that'll give me another question to ask him. The other thing you talked about, elective surgeries and let's just call it postponed procedures and that kind of stuff. I think it was Mark Harrison. I think it was Mark Harrison, CEO of Intermountain. It was the only one I heard give a number, and I think he said they attributed close to 100,000 deaths this year from people not getting treatment at the right time, or not coming into the ED, or those kind of things. I'd be curious to see where he got his number, but that wouldn't shock me if you're talking about the entire United States, close to 100,000 deaths due to.
He was talking about the United States. Okay, I thought he was talking about like Intermountain.
No, he was talking about. He was talking, and I'll have to go back and look at the transcript and see what his source is. But I mean, that number would not surprise me, really at all. So telehealth. Is interesting because it comes down to incentives again, right? So one of the things we're seeing is that these fee for service arms are essentially saying, "Hey, that was a really fun experiment. I did like telehealth. Boy, that was fun. But you know what? I'm bringing people back in to see them in the office. I have a mechanism for doing this. I have real estate I need to pay for. I have staff I need to pay for. And so the incentives aren't aligned. So it's bringing people in. That's one thing that's going on. The other thing that's going on is you're seeing states, because we haven't seen it at the federal level, to say, CMS to say, hey, we're going to continue to fund this, mostly because they don't have the money to do it. And we're seeing states start to step up. So you've seen Massachusetts, and I think New York. I haven't seen another yet, but those two, Massachusetts being the most bold, essentially is going to backstop all the telehealth and say at least telehealth for behavioral health, and they're going to backstop all of those visits and keep those funded at the COVID rates. And I think don't you think there's going to be a big push on this to make sure this stays funded?
I hope so, but you talk about the all these perverse incentives, and we've never talked about this, but I am Canadian, and I used to live in British Columbia, and while I was there most recently, which would have been like 2011 timeframe, the government was funding telehealth visits higher than in person to try and drive the behavior towards telehealth. And the minute they stopped doing that, everybody dropped telehealth visits. So there's like so many things going on here. It's not just funding, it's think preference, going back to your point about real estate, but possibly what might change this time is that everybody's reevaluating the real estate, right? Like,
Yeah.
not just healthcare, like look at all the office buildings that are empty. Everyone is saying, how should we be thinking about this? So I really hope that healthcare isn't making a decision for patient care based on real estate.
Yeah.
And that they are actually thinking about, like if you think about it, like we're in a pandemic, right? If I had the flu, you don't want me going to a doctor's office. Like that is a perfect telehealth visit. So I'm not going in there and infecting everybody else. So
Right.
like there's some really, really good cases. And that'll free up, the in-person for the things that really need to be in person.
Yeah.
So
absolutely.
I don't know. I hope so. I'm hopeful, but I've seen things that, you would really hope it wasn't just money based.
Yeah. Well, if the listeners want a full breakdown on the JPM conference, I did do an episode this Friday with Rob DiMache, former CFO for UPMC, and he goes through the nobody better to go through the financials and what it means and diversification and all those things. So if you want a really detailed breakdown, go ahead, you can go over there. I'm also doing a bunch of shows on Today in Health IT. So you can go over to todayinhealthit.com, listen to some of those where I broke down some of the themes and whatnot. And there's going to be more of those this week that I'm still rolling out. I do want to get to some other topics.
Before we go off JP Morgan, most important question was, did you have to pay for a Zoom call the way you had to pay for a table to sit in the lobby of a hotel? How did that work this year?
My wife charged me $800 a night during the JP Morgan conference. So I felt really at home, and it felt right. I don't think people can really appreciate how expensive that conference is to attend. It's nuts.
Yeah.
But everybody's there, and some of those people, the only time I'm going to see them this year will be at that conference. So, if they do it again in person next year, I will be there in the hotel on that floor, watching all those CEOs go up to the podium. It'll be interesting to see if we're at that point in January of 2022.
Yeah. I'm hoping that conferences end up being a bit more hybrid, that you can participate without, there's huge benefits to being in person, but you can't always travel. I know that, I think that the HLTH conference, it seems, I didn't attend this year, but it does seem like they did a good job of going going online. And I can imagine them doing more hybrid in the future because they're a little bit, they're a newer conference. Let's just say that.
Yeah, they're more tech savvy. But I'll be honest with you, the benefit this year, because the JP Morgan conference pulls you in so many different directions. There's individuals you want to sit down and have a conversation with. There's you get invited to events that are right in the middle of some things that you want to watch and whatnot. So for me, I'm always pulled in a lot of directions. The nice thing about this was I missed, and I have a list of ones that I'm still listening to, a bunch of the presentations, and I went back and listened to them later, which is great. So if I sit through the nonprofit track, I missed the CVS presentation. I missed the Walgreens. NVIDIA presented, Teladoc, Centene, Nuance. I mean, those are all things I want to attend, but you can't be in two places. So, let's talk a little bit of vaccine distribution. And it's interesting. I did a post. You'll love this post. And actually, I'll hit the post because I want to share some of the things that people are talking about with regard to this. I said, try this. Hit your state's website and try to get information on vaccine distribution. Now go to the county website. Now go to your health system website. Post your results below. How did it go? Was it easy to find? Do you know how to schedule an appointment? Do you know when you can schedule an appointment? Are you clear on the efficacy of the vaccine? Do you know which vaccine you're going to get? Does it matter to you? And I posted some things here that people are saying, and one of them is, we spent $10 billion to develop vaccines, and why we are not spending money to introduce the public to the vaccine. A physician in Charleston-based Medical University of South Carolina told Bloomberg, and they said we can do this better. Well, this is probably the post for me this week that got the most action, and people did it. They went out. So somebody from the state of California said, hey, that information's almost impossible to find, but I know exactly how many deaths there are in the United States. So they want you to know how many deaths there are, but they're not really helping you out on that. Sue Shade went out. She's one of the rotating guests. She went out after the show and said, my state, Rhode Island, still is only showing high-level timeline for phase 1 groups. Nice visual showing phase 1. So that's a plus. I asked virtual chat about over 65, most recent CDC guidelines, and got a non-helpful answer. My health system website is not showing any information. We had somebody from Texas say they scheduled and got in, and the information was readily available. In my state of Florida, which I noted, I can go to the county website, actually hit a schedule button, and schedule the vaccine. Now it's interesting. It's not until I get in there that it says, what's your age? Oh, you're not eligible yet. So that tells people I'm not over the age of 65. But in Florida, we're actually to the next level. We're giving it to, we did the long-term care facilities and nursing homes, and now we're starting to do people over the age of 65 are starting to get lined up for the vaccine as well. Catherine Sullivan, who is always giving me trouble, but I love the trouble she gives me because she always is talking about the people that we forget about, or the people that are not connected. And she talks about the mentally ill, and she's really trying to give me heat on this. She's like, this doesn't take into account the mentally ill and the homeless, and how are they going to get to it? And I was like, Catherine, that's a great question. What do you recommend? She says, we have to figure out a way to go to them. And she's not wrong. That's true. I don't know who's doing that. I don't know if that's a public health effort or if it's a hospital effort.
I actually don't know who's doing this but in my local park, there's now a COVID test site, like just in the park. So
wow.
That might be a way to do it. Yeah, I was reminded of, I don't know if you saw there was an article in the New York Times yesterday, and it was talking about, the trials of getting signed up. And it says, I'll quote this because I think it's quite relevant to IT. Buggy websites, multiple sign-up systems that act in parallel but do not link together, and a lack of outreach are causing exasperation and exhaustion among older New Yorkers and others trying to set up vaccination appointments. So, we've got the typical health system or healthcare, systems not talking to each other. And then we've got, and who we're trying to get to are the people who might be actually hardest to get to. And it, reminded me a little bit of a startup I've been advising called Can Do Tech, that is tech support for seniors. And they've actually started helping seniors sign up for their COVID vaccines. So it's one thing to put something out there. The other is is it actually usable? And as we know, usability is not always the highest order of things in healthcare. And I don't know, did anybody think through this? Could you actually sign up, as you were saying?
Yeah, and what's interesting? One of the articles talked about the federal government didn't set anything up. They pushed it down to the states, and the states were sent scrambling. And I thought, what? That's how I want it to be. I don't want the federal government to come out with a program. My gosh, we'd be talking about, are you in line for the vaccine in June of this year? By pushing it all the way down to the state. And one of the things I like is that a lot of the states really, they went to the health systems and said, look, what's your mechanism for reaching people? And what they realized is the health system's mechanism for reaching people is their portals, and their portal sign up is still, the best are about 50% of their patients. That's not of the community. That's 50% of their patients. And so that's their outreach mechanism. Yeah. And so they stepped back and said, okay, well, that's not going to be enough. What are we going to do next? And then but they still engaged the local health systems. And then they stepped back and said, all right, what are we going to do at the county level? And this is why I like what Florida, and Florida took a lot of heat. They had lines and some other stuff, which always happens at the beginning of something like this. But it's a common scheduling system, and they're using Eventbrite. So they took heat for using Eventbrite. But you know what? We've all used Eventbrite. It's really well thought out user experience. It's really easy. You can provide them additional information. So that's what they're doing at that site. I'm not trying to score political points in any direction here. I'm just saying I live in Florida. I'm watching this sort of play out. My neighbors did call me and say, "Hey, how do I get the vaccine?" And it turns out, the nursing homes and long-term clinics was the best orchestrated distribution, even in the state of Florida. And what they ended up doing was because they're like 86 years old or something like that. They ended up getting the vaccine, not from the hospital, but at the local long-term care clinic, yeah, which they're signed up to join in for long-term care in a year or so. So
you asked me about long-term impacts on telehealth. I'm wondering, will this have positive long-term impacts on public health? And I was reminded of a comment that a ED doctor at Kaiser here in Seattle said to me a while ago. But we've gotten to this point where we have often wildfires in the summer and really bad air quality. We had terrible air quality for the basically first 2 weeks of September this year. And what he said to me is he had no way of searching the EMR to find his patients that had asthma, to send them an email to say, do not exercise, do not go outside, and I'm just wondering, like, in trying to find these people who are qualifying for a COVID vaccine and doing this kind of search, will we get those kinds of capabilities? Like, he wanted to proactively reach out to his patients and he couldn't because he couldn't find them. So I'm hoping that this will, what do you think? Like, is this going to have long-term?
It absolutely, it'll absolutely have long-term impact on public health. I mean, we're already seeing just a bunch of conversations start to kick in of, what information do we need? And, when the pandemic started, we still had the massive bureaucracy on top of this thing. And people were just saying, look, we're in the middle of this thing. I don't have time to collect nonsense information that you need for this and this. Why don't you tell us exactly what you need? And that's what we're going to give you. And some people started working on, what are the data fields we actually need in terms of the pandemic. And so the same way I'm talking about that is the same way I'm thinking about public health. I think people are going to step back and realize, first of all, I think we're going to define public health a little differently than we have before in the elements of things that we need in order to be effective, and who are the players in public health. And I'll give you the one example, and this was a JP Morgan conference. This is a combination of JP Morgan conference and vaccine distribution. CVS has done close to 1 million COVID vaccinations already. And wow, they haven't done them in their stores. They got the contract or whatever to do them in long-term care facilities because they were close enough. They had the distribution mechanism, and they had the healthcare system relationships. And so they took their clinics, they went out to these long-term care facilities, they took the vaccine with them, and they went to all these places. They did about 1 million. And they said the next step for us is, and to be honest with you, it's probably much more effective than some of the things we're trying to do today. And I think these are the kind of conversations we'll have. So they're going to go out, or the next step is the federal government will essentially make them a distributor of the vaccine, and they're just better at reaching people, right? CVS knows how to get a hold of me. The local health system doesn't know how to get a hold of me. I haven't been there. They don't even know I exist in this market.
Yeah. Yeah.
And it's not only that. This is why we talk about new entrants. And new entrants is always a topic at JPM. I mean, this is why the CVSs, the Walmarts, the Amazons, and others, and the disruptors are seeing an opportunity here. I mean, the landscape has changed so dramatically that there are opportunities to step in and say, look, you could try to build this whole network of things out, but if you wanted to do, nobody does distribution better than Amazon. Nobody's in every market better than CVS and Walmart, and they literally, health systems grew by acquisition, right? So they're not necessarily all in the right places, but when they put a Walmart in your local location, they do all sorts of research on growth patterns in that community. I mean, they are in the right spot and they put in nice big parking lots and all sorts of other stuff. And I have a feeling that public health partners will look a little different coming out of this.
You know who else is in the right spot is Starbucks. I think that if the health systems wanted to get out in the community, they should look where the Starbucks are.
I'll take a latte and a COVID vaccine, please.
Yeah, why not?
Well, seriously, they are everywhere. I mean, I guess the difference is that they would have to invest in the infrastructure to.
Oh, I'm not saying Starbucks should do it. I'm just saying, like, if you want to be where the people are, that's another indicator. Like, put your health clinic right beside a Starbucks.
Yeah, I mean, one of the first.
Actually, which there is one in Seattle, in the neighborhood where we used to have our Wellpepper office. There was a Zoom care right beside a Starbucks.
Yeah.
I don't think that was a coincidence.
Yeah, I don't think that's a coincidence either. Vaccine. One of the things we talked about was the challenge of tracking the vaccine in the EHR and then getting that information out and whatnot. And one of the stories I wanted to hit on, Vaccine Credential Initiative, was launched, and this is pretty interesting in that. Let's see, Vaccine Credential Initiative. Let me find this one. Participating organizations, which is organizations like the Caring Alliance, Epic, Cerner, that's big news, Microsoft, and others. Participating organizations will agree to offer individuals with digital access to their vaccination records using the open interoperable smart health cards specification based on the W3C verifiable credentials and HL7 FHIR standards according to VCI. So essentially what you're talking about here is we've solved the first problem, which is where you're going to track this, and we are going to track it in the EHR. We're going to track it wherever we track it, and my guess is most of it's going to be in an EHR. Okay, great. Now we need to, the person shows up for the first dose of the vaccine. They need to get the second dose. They don't go back to the same place. They need to show that they've had the first dose. We need to get that information sort of interoperable. That's what this is about. This is about using FHIR to go in, get that information, be able to move it around, also put it on your mobile phone via the smart health cards specification, and be able to move it around. I'll tell you what's interesting to me is, you're hard pressed to find a place where Cerner and Epic are in collaboration. And I mean, they make announcements all the time that make it appear like, hey, we're working for the good of the community. But this is one of those cases where they are absolutely working for the good of the community. Right. We have all the things that have happened around this, like 21st Century Cures, FHIR really making a move forward, plus the urgency of COVID coming together to create the perfect storm for, all right, let's see if we can do something, if we can build a mechanism for sharing this information and getting it into the hands of the patient. I think this is a potential game changer, because for years we've been saying, we can't share that information. This is too hard. But if they're able to do this, doesn't that mean we're going to be able to do an awful lot of other things coming out of this?
It doesn't. I mean, I think the question is the value of the data to the health system, right? Like that sort of feels like vaccination data is not that valuable.
Are you saying that the health systems will put up a fight if it hurts their competitive advantage?
Yeah, that's what I'm saying. I'm saying many of the protectionist data policies in the past have been because they think that the patient's data is their IP, which I completely disagree with, and always took that stance of like the patient owns the data about their health, and they give technology companies like
Yeah,
and doctors, permission to use it. The health systems actually say they own the data, and they give the patient permission to see it. So I think I'm sort of thinking, like, with vaccination data, it's not that sticky. Like, you don't think, oh
yeah,
wow,
yeah.
I got vaccinated at this place. It was such a great experience. I'm going to get all my vaccinations there. You get it
No.
wherever it's like most convenient. So it will set up the technical infrastructure. I don't know if it'll change the behavior.
Well, but I don't think it'll change the behavior either, but here's what it does set up. So we have the transparency rule, which puts the shoppable services out there. So we have a new set of data that we can put in the hands of people. We are going to prove the ability to move this data out, move it around. And then the question becomes, the federal government keeps pushing. This is the first set of data that you're going to have to expose via FHIR. And then it's the second set, then it's the third set. And potentially what we get to is a situation where I can finally move from place to place, not be really captive to where my data is being housed. I can move with my data, and then you'll see different plans start to emerge within the community. That, I think, is the hope. And again, I mean, the thing I love about this is a different focus and different emphasis, but CMS and HHS has been consistent now for the better part of almost 2 decades in terms of their desire to get the data into the hands of the patient, to empower the patient. We can argue whether it will and what we have to do to the data to get patients engaged, but they've been pretty consistent now, and I don't think that's going to change under the next administration. I think it's, the emphasis might change. The emphasis might go from creating a market under the Republican administration to, maybe Medicare Advantage for all under the Biden administration. But at the end of the day, I don't think this view of how data has been locked up and needs to be freed up in order to support cures, in order to support cost reduction and those kind of things. I don't think that's going to change at all. Do you?
No, I don't. No, it's not going to be fast. What's interesting is I actually remember, and I haven't even, say whether they exist anymore, but there were like startups doing vaccine records for kids because it was so hard to keep track of that for parents, which seems like should be a feature of a, EMR portal. So yeah, there's no question that the piece of paper is not a good way of tracking this.
Yeah, absolutely. So Anne, what do you have a story or anything to that you want to throw out there?
Okay, this may be going a little too far, but I think it's pretty interesting. And this is, again, it's from a personal story, but as we're talking about vaccine rollout, a friend of mine was telling me about what was happening in France. And so what's happening in France is it's cultural. They are sending out the notifications of, you can get the vaccine. And then they're giving people like 2 weeks to decide if they would like it. And so they basically, I think by the end of last year, they had vaccinated 130 people. But it's a complete cultural, like, it should be up to the individual to decide, and we're going to make this equitable. And instead of saying, here's your appointment date, and if, you can come or not, but your appointment's going away, they're like actually giving them this time. And as a result, they're not actually rolling out the vaccine. So, when we see the things happening unevenly in the US, I think we're doing a better job than that story.
Yeah, we're doing a better job, but this, and we're not going to have this conversation. Actually, we're coming up to the close of the show, but this is rolling out a vaccine in the age of social media is another hurdle in and of itself. I mean, what is accurate information? I mean, the number of times I have to answer questions to people that I'm like, well, that's common knowledge. It's like, well, it's not common knowledge because half the stuff they've read or a quarter of the stuff they read contradicts what I'm saying to them.
Yeah. Yeah, no, I think it was more that just, that you said you don't want a federal rollout. That's an example of a federal rollout that's not working very well. But also I think goes back to you can design whatever program you want, but so much of it is, the people and the cultural aspects are the things that can screw up everything. I think that was my bigger point there.
Right. And so you're saying to be culturally relevant in France, they should distribute the vaccine in wine. So if they had a wine that was actually the vaccine,
well, maybe my cafe idea is the right one.
Cafe as well. That would be true. That's funny. And thanks again for joining me. I appreciate it. And we will do this again in about 6 weeks.
Sounds great. Thanks.
Thanks. What a great discussion. If you know of someone that might benefit from our channel from these kinds of discussions, please forward them a note. They can subscribe on our website, thisweekhealth.com, or you can go to wherever you listen to podcasts, Apple, Google, Overcast. That's what I use, Spotify, Stitcher. We're out there. You can find us. Go ahead and subscribe today, or send a note to someone and have them subscribe. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, and Starbridge Advisors. Thanks for listening. That's all for now.